Hello, happy Friday. Welcome to the Assisted Outpatient Treatment Community of Practice. We did advertise this particular community of practice a little bit more widely, so there may be people here that haven't been before from different parts of the system of care. So if that is you, welcome for the first time. This is a community of practice that we hold on the fourth Friday of every single month, where we talk about AOT related things and give ourselves opportunity to collaborate, brainstorm, and problem solve together. So yeah, we have, if you received our email reminder, you know that today we have Dr. Brian Littleton here to give a presentation on how to conduct a thorough AOT assessment. So without further ado, I'll go ahead and introduce Dr. Brian Littleton. Dr. Littleton is a licensed psychologist with a primary focus on SMI populations and psychological assessment. He is a professor of psychology at Mott Community College and serves as an adjunct faculty in the counseling psychology program at Wayne State University. That's where he teaches psychological assessment. And Dr. Littleton maintains a private practice specializing in evaluations and assessments. Additionally, he's a psychologist for Genesee Health System's Assisted Outpatient Treatment program. So Dr. Littleton earned his bachelor's degree in psychology from Wayne State University and a master's of science in clinical health psychology from the University of Michigan Dearborn and a doctorate in counseling psychology from Western Michigan University. He's completed an APA accredited internship at the Battle Creek VA Medical Center, focusing on recovery and SMI. So yeah, that's Dr. Littleton. Thank you so much for being here. I'm going to pass it over to you. And yeah, again, if anyone has any questions, feel free to jump in.
Well, again, thanks for having me. I promised them that I would not be long-winded as I can be. Today I'm just going to talk a little bit about conducting an evaluation for an assisted outpatient treatment. I'm going to be focusing mostly obviously on the people who are not needs, who are outpatient and is coming into the evaluation. So not necessarily an ER evaluation process or someone on the inpatient floor, although some of that can be applied to what I'm going to talk about. But this would be an individual that's already not hospitalized that would be coming into for an evaluation. So some of the things I want to discuss today is just kind of going a little bit over the criteria for the court mental health treatment, conducting the evaluation itself, going over the clinical certification, then some time for questions and answers that we're going to spend. Some of this is going to be knowledge that you already have, but I do want to kind of maybe present it a little bit different in terms of providing ways to think about some of this information. All right, so the first thing is understanding, looking at the statutory criteria for the AOT and the eligibility. It's important as a clinician that you actually look at this information. One of the things, the ways that I always approach my evaluations is understanding what the actual referral question is itself. And so I'm already looking at this from the first referral question is, does the person have a mental illness that's defined by the Michigan Mental Health Code? And so the Michigan Mental Health Code does outline what a mental illness is. Again, it's about a substantial thought disorder of thought or mood that significantly impairs the judgment, behavior, ability to recognize reality, and ability to cope with ordinary demands of life. Within that, they also have to meet a diagnosis. You need a diagnosis that accompanies that. So one of the first questions when you're actually doing your evaluation is to find out, do they meet that criteria? There are some exceptions to this, and interestingly enough, it came up within the last week or two. I had an individual that had Alzheimer's, and so dealing with dementia is excluded. They do not meet this sort of criteria unless there is a caveat. They have disturbance of behavior, and so that little tiny clause or mental health issue that goes along with it. And so sometimes you have to kind of look at making sure they meet the diagnostic criteria. So you understand the law before in terms of what actually meets that criteria or not. Also, if you have an individual with an intellectual disability, would also be an issue as well. So they have a different process that they will follow. And so you always look at the evaluation and come into it looking at the referral question. The second referral part of the referral question. If they do have a mental illness, what is the criteria for the court order treatment? And it really boils down to these three areas: that they're a risk to their self or others, they can't attend to their basic needs, and inability to adhere to treatment. And so those are the three areas you're going to look at. And so those are the three areas that you're going to assess. And so this is when you're conducting these evaluations, they're a little bit different than maybe your traditional biopsychosocial interviews, that you're going to look at it and approach it a little bit different because you have very specific requirements that you may need to look at. And so those are the three areas that you're really going to focus in on as it relates to the evaluation itself. All right, so when it comes to looking at your evaluation, one of the first things you're going to do is evaluate and review all the medical records. You have to spend time looking at the medical records, and that includes everything down to the case notes from if they have a caseworker. You will spend time looking at that information. You will spend time looking at if they have medication drop off. Are they even getting their medications at the medication drop off? Are they missing that's all part of the medical records. On average, some people just spend time looking at the last medication appointment they may have with the psychiatrist or their last casework. I like to do a little more deep dive. That's just because one of the things that I'm always thinking about is I'm thinking about testimony in the back of my head, is always in the back of thinking about, am I going to get asked this question during testimony? And the last thing you want is to be testifying in court and you're hit with a question from a record that you did not see. And they're like, well, how far back did you go in your records? That's a question that I've often been asked during testimony. And if I only say I went the last year of records, they will try to, the defense may try to come back, well, what happened 2 years ago, 3 years ago, and how they were doing. And it's just, and part of the job is, as a zealous defense, that's their role to perform, but you don't want to be caught flat-footed. So I always recommend the most thorough review of records that you can do when it comes to this. So I will go back several years. A lot of times I'm not going to look at every single case note to be honest, going back, if a person has a 15-year history, there's no way I can spend 15 years reviewing it. But what I will look is maybe the biopsychosocials for the last few years and look at the updates and look at the trajectory of how things have changed over time. And so those things are important. I may look at a few of the evaluations that were done by psychiatrists in the past to see how the diagnosis may have changed, because that's something that, again, I hate to say gotcha questions, but you get gotcha questions in court. And so you have to be prepared for those. You may see the diagnosis change. And so you need to be able to look at why did that diagnosis change and be able to answer that question when it comes time for court. Then, of course, part of the clinical information is conducting the clinical interview itself. And this here really is important, that you conduct a good, thorough clinical interview. And that's what I want to spend a little bit of time talking about, is actually how you actually go about conducting that clinical interview, questions to ask, things to look out for when you're actually interviewing them. So when we're conducting a clinical interview, it's important that you establish rapport with the client and consumer that you're meeting with. And when you understand the client and the consumer that you're meeting with, a lot of times there's a reason for the referral. And so they're likely to maybe already treatment resistant. Otherwise, they probably would not be getting the referral for an AOT usually. And so there's probably some treatment resistance that may be built in. And so in order to conduct a good interview, you need to make sure that you establish a good rapport with the individual. And so a lot of times you need to be open and honest with the consumer about why we're doing this evaluation, and tell them why. I know a lot of clinicians at times like, oh, I don't want to tell them, and you try to hide, that does not work well when you're working with this population. Again, if you're working, usually this is going to be someone from an SMI population. There's already maybe some distrust of the system. You don't want to aid into that. And so you want to be open and honest with them. I tell them, this is why you're being referred for an evaluation. And also I let them know that I'm a neutral party in this, that I am going to approach this neutral. Just because you were referred for this evaluation does not mean that I am going to agree with the case manager, whoever made the referral for that evaluation. Let them know that you are a neutral person in this evaluation. The second thing is I do that's been very helpful over the years, because I work in my private practice. I've learned this from that. I do a lot more kind of forensic evaluations. But small talk, that helps build up that rapport with individuals. So if a person comes in there, example, you have a Pistons cap on, I will just start up with small talk. Hey, did you catch the game the other day? I may spend 5 minutes just talking about the Pistons, basketball, who your team is. Oh, you watched the draft. Oh, did you eat lunch? Oh, what'd you eat? Oh, did you try this restaurant out? That small talk, it helps encourage openness. It also lets that person on the side who may not be trustful, who distrust, not trust you, begin to trust you because they see you as a human. They have to see you as a person. And so that's something that's going to be helpful in terms of getting the information you need to conduct your evaluation. Another thing you need to do is you got to balance this interview, your clinical interview, with this conversational style versus this interviewing style. I tend to use a more conversational style. And what I mean by that is we're just talking. I don't, versus this interview style is question, question. Do you have this diagnosis? Do you have this? Do you have that? What would you, and it's like, it's a job interview. That clinical interviewing style of this, it's very easy for people to become very defensive, and they're not going to reveal their real selves to you. And it's actually a lot easier for them to be a little bit more dishonest or try to come away from that. When people have an open, free-flowing conversation, you'll be surprised what people reveal. That's where I get a lot of good information from. Now, toward the end, I may have to narrow down, go to some interviewing if that information did not come out during my conversational style. But I always recommend use a conversational style when using this interview, when doing this type of clinical interview for these evaluations. So again, just free-flowing conversation. Tell me about this, and you're just asking them, and you may deviate a little bit. Very open-ended is how you want this that to flow. So in terms of your evaluation and within this interviewing, you have to do the diagnostic assessment. And what I mean by that, this is that part that's establishing that first criteria, meaning that do they have a mental illness? And the way that you're going to do this is you have to understand, look at their mental health history. You want to gather detailed information on their past diagnoses, their treatment, any hospitalizations. You're also going to look at their current symptoms. What symptoms are they having now, and how does this impact their functioning? And also going to look at some of the past symptoms. If they're on medication, how are they prior to medication? How are they on medication? And so when I'm interviewing them, sometimes you have to find out, do they even believe they have a mental health illness? Do they have a mental health history? Do they believe they have a mental illness? So I will ask, do you have a mental health diagnosis? And if so, what is that mental health diagnosis? And then you have to find out, well, you'll find some people say, I have bipolar, or I have a little depression, even though their diagnosis may be something completely different. I run with that just for a minute, and then I come back, well, what does it mean that you have that diagnosis? Because that's getting into the insight for the individual. So a person can easily state, I have schizophrenia, I have bipolar, this is what's been told to me. They can recite it and tell you this, but they may not necessarily have insight into it. So a lot of times I may have people say, oh, I have bipolar. Well, what does that mean to you? What does it look like? And then they'll say, oh, it just means I get a little sad every now and then. And there's like, okay, anything else? Well, how does that impact you? And it's not realizing, oh, well, they were going to exclude the part where they may have tried to harm themselves or other people, and that's related to the diagnosis itself. And so you want to spend time to find out what that diagnosis means to the person. Also, you want to ask, is the diagnosis correct? Do they believe it's correct? And so you'll have people who'll say, well, that's what they'll say, I have schizophrenia, schizoaffective, whatever the diagnosis is. And then you ask that question, do they believe it's correct? And they'll say, no, I don't believe it. And so then that's another fault question. well, what diagnosis do you believe you have? And then they may say, well, actually, I don't believe I have any of those diagnoses, or I have this diagnosis, which may be. And so with that, you have to understand why they may say they have a different diagnosis or not. So you need to uncover and spend time getting to understand that aspect of it. And then you, again, like I mentioned, you want to ask how it's impacted their life. Also with this diagnostic assessment, this portion here, you want to find out, have they been psychiatrically hospitalized in the past? It's amazing how many people I've evaluated and they'll say no, despite records on top of records, like, hold on, you were just there 2 weeks ago, and they'll still say no because they'll say they're in the hospital for some other reason. So a lot of times we have to spend time going back over that. Well, have you been hospitalized sometimes because of this? So you have to break it down even to, have you been hospitalized because maybe you wanted to hurt yourself, or maybe some things weren't going right? And you may have to not use this term psychiatrically hospitalized. You have to kind of use another term and kind of talk around it to get them to reveal why they were hospitalized. And then you have to sometimes confront them. So, well, the records I have says that you were hospitalized for this reason. Is that correct or is that not correct? And allow them to opportunity to explain themselves. So next thing is you're going to look at their medication and look at their treatment adherence. And so one, are they taking the medication as required? Are they attending their treatment as required? So a lot of this is going to come directly from asking them. And you may ask them questions such as, can you tell me all the medications that you're using? They may just indicate they're taking maybe for physical health medications. Or they may say they're taking some medication. I don't know the name of them. You want to find out, and then if the medications, what are they taking them for? So you want to spend time to find out, what are they taking the medications for? And are they taking them as prescribed if they're taking medications? One of the things that when it comes to medication is a lot of times there's a reason they don't like taking medications because of the side effects. And so with this, you need to normalize this to a certain part is what's going on, why you're not taking the medication, what side effects don't you like. Those are some things that you will get into with the individual. I always ask them a question, if you had a choice, would you take medication, and why or why not? I will ask them, what happens if you don't take your medication? And then sometimes, again, depending on the response, you kind of have to confront them with the evidence that you have based on records and ask them to explain the discrepancy. Your records say when you didn't take your medication, you end up being hospitalized. And when you confront them, I always do it what I call the Columbo, right? This kind of play dumb with it. Like, well, I kind of see that it's hospitalized here. Kind of help me make sense of this information that you're hospitalized after you stop taking your medication. And so I kind of usually use that kind of technique with individuals. And again, asking them why they may miss appointments is another thing. How did they miss their appointments? What's the reason? Was it a transportation issue? Was it that they just didn't want to come? That's important because those are questions that you need to be prepared for when you have to testify. Because again, that goes back to, in the back of my head, I'm always thinking about the questions I'm going to be asked in court to defend the decision that I'm going to ultimately come to, whether they need an order or not. When it comes to look at the treatment records, one of the things I do, though, is I calculate the percentage of no-shows. So I may say over the last year, I see that you missed 40%. That's good data and information that you can use, and you can point out to the patient and consumer, as well as when you testify in court, how many appointments they have missed related to. So I know she missed this many med appointments. I know you missed this many appointments with their caseworker, maybe for therapy, or whatever it may be. I calculate a percentage. It's a nice way to look at it. So if someone's missing 30, 40, 50%, even more, then that's someone who's really not adhering to the treatment at all. So those are some things that can be beneficial that you can look at. So this is the big one here, what I call the potential dishonesty. And I'm not saying that they're lying to you, okay? But it's when yes means no. If you ask them directly, will you take medication? They know why they're there. Yes, I'm going to take my medication. Are you going to go to treatment? Yes, I'm going to go to treatment. I'm going to meet my caseworker. I'm going to do all these things. And so that's what's going to come up in court. And you have to deal with this. Well, when they're saying yes, but when they really mean no. And what I mean by saying no, I mean they're not, their history does not say that. And so what you're going to look for is consistency. This is going to come through your observations, your clinical interviewing skills. You're going to look for consistency in their responses over time. What does their history show? They're saying yes to you now, but what about in the past? And so you're going to ask, you're going to have them reconcile. Well, I know you're saying yes now. What's different this time? And have them explain what's different. And this is sometimes that question alone will provide enough insight for you to get at, well, they're saying it's only surface level. They don't have any depth to really what they're saying. They're just saying, yes, I'm going to take my medication this time. What's different than this time? They don't have any strategies of what's even going to be different, how they're going to remember to take their medication. And so you're going to listen for those plans. And so that consistency. Also, you'll find even consistency within the interview itself. You'll be surprised the different answers you get within 10-minute span of an interview. And this is where that conversational style kind of helps. When it's just more open format and free flowing, they'll reveal things and say about medication, like, oh yeah, I hate the medication. It made me feel this way. But then you come back later in the interview, ask them, are you going to take your medication? Oh, well, yeah, I'm going to take it. Well, earlier you're just telling me you said you didn't like the medication because it did this, you weren't going to take it. And just so sometimes you can address that consistency right then in the interview itself. You're also going to look for some of the nonverbal cues that they may get. Look at the body language when they're stating what's going on. And again, you're going to look at also some of those open-ended questions. You're going to use that. Have an open, honest conversation about the challenges. You're prescribed this medication. Why didn't you like it? What's some of the side effects? And so I always discuss side effects with the people that I'm evaluating, because the truth of the matter is I want them to be agreeable to, in fact, to put them on AOT. It's a lot better that they're still going to be agreeable to the treatment recommendations than going against it. Even if I don't believe they're going to follow through and they need this order, I want them to at least be agreeable to the idea of some of these things. So I asked them, what are some of the side effects? How is this affecting your life? And the way I do this, sometimes to kind of get this open conversation, I use a little self-disclosure. And it's something, when I say self-disclosure, a minimal thing. So I tell them, hey, I have to take eye drops, and it makes my eyes dry when I take these eye drops every day. And I hate taking, I know remember to take it every morning, the eye drops, and I know how that can affect. So I kind of normalize it, but by normalizing it, I'm getting this open, honest conversation about side effects. And then they can say, usually the side effects come in, I don't feel like a zombie. I don't feel like the lack of energy. And then usually it's sexual side effects. Those are the big three that I normally, and just be honest with them and validate their feelings as it relates to those side effects. And let them know those are real things, and let them know, well, if you take medication, maybe you can talk to your psychiatrist or prescriber about different alternative medications or things you can do. So those are a few brief ways that you can kind of address, some of the potential yes means no. So the suicide risk assessment, when it comes to this, you're going to look at some of the static versus dynamic factors. So we know static factors are historical things that cannot be altered, like their age, what's pushed them at higher risk. And dynamic factors are they using substances? That can be something that's changeable. And so I always look at those factors when it comes to harm to self. And when it gets to the criteria, it does say more immediate. And that immediate question really can catch people up if you have a good lawyer who will try to hammer you on what does immediate really mean? Does it mean next 24 hours, next week? And so I look at this, what puts them at a higher risk moving forward. If it's something 6 months out, then I'm not going to count that as immediate. Also within this, you want to look at the protective factors when it comes to their suicide risk assessment, because I like to balance that out. Although they have these great risks for harm to self, what are some protective factors? I like to always write those protective factors in my evaluations. When it comes to asking the questions itself, you'll get people, you ask them, have you ever attempted suicide? They're going to say no, or it may be yes. Those. So you have to kind of be a little bit more, find ways to kind of get them to be open discussing it. And so you have to maybe use different language. So have you ever felt so sad and depressed that you felt life was not worth living? Um, you wanted to ever take your own life? Those are some things that you may want to kind of go about going there. Also, how did you plan to go into the planning idea? How far did it go? When it also comes to harm to self, this is come back to the clinical cert, which I'll talk about briefly when I get there. It's not only suicide, it's unintentional harm to self as well as part of the clinical cert. And so we'll talk about how you assess for that. So this comes back to the assessment of how you harm to other people. So you have to look at the contextual factors, such as their social environment, any stressors that are going on. Do they have access to weapons? Then you can look at historical factors, such as criminal behavior, substance abuse, past behavior. One of the questions I always ask, what's some things that make you angry or upset? And some people will lie to you and just tell you, I never get upset. And that right there is kind of this club, like, never? All right. Well, then you got to confront them with some of the data that if they've had some historical things that happened in the past where they have acted out and harmed others. But then again, I'll say, wow, as I said, well, you never to get angry. I get angry. What do you mean you never get angry? So then you may get them to say how they get it. How do you manage that? How do they manage never being angry? Or if they do get angry, what do you do? How do you manage it? Have you ever got into any fight? If you say fight, they may say no. But if I say, well, you ever been in a situation where you hurt someone, where you punched or kicked them, that question, they may say yes. So a lot of times when you're interviewing people, the way that you phrase the question alone will elicit different responses. And so if I say fight, nope. But if I say, oh, you ever slap somebody, kick someone, hurt someone, you may get a different response. Then I asked them a question of, do you think you can stop yourself from hurting someone if you got really angry? And of course, you want to ask them, is there anyone you're thinking of hurting at this time? Or someone that you want to get back at? And those are questions you can ask that in terms of harm to others. You also want to look at the functional impairment, how this is impacting their day-to-day living. And you want to look at how it affects them socially, their work, family, and their overall self-care. One thing that I don't have them fill it out, but I look at the inventory of psychosocial functioning that the VA has produced, and it just has different questions on there that you can kind of use to look at different areas. This here was a copy of the brief where it has, I believe, like 9 questions. And so you can use this here as a tool to kind of help you look at functional impairment. But if you download the full inventory, has tons of questions that covers different areas. There's some great questions on there that you can look at to assess functional impairment and how it relates to their mental health and how they're doing. And so I will sometimes use this even as give it to them as a rating scale. I'll do it as orally. So I don't use it in a formal sense of fill it out, but I will take some of the questions from there and actually use it. And maybe on a scale of 1 to 10, I will use it and see how they will align on there. Some of the questions I also will go through is, have you found yourself doing well for a while, then had a tough time that just seemed to last? When those experiences occur, do things get better or are things getting worse for you? Are you being treated for any health problems? You want to also find out where they're living at this current time. Do they have any close friends? Who do you lean on for support? Those are some things that you can kind of look at for their social. And that puts into, are they isolating? Do they have a support network? And that also is going to help you when it comes time for your treatment recommendations. So you want all this information as it relates to treatment as well. So when it comes to developing a treatment plan, as you know, when it comes to your assisted outpatient treatment in your corridor, there's pretty much a checkbox of individual group therapy, supervised living, the way case management services. So that's like for the court, but within itself, in my evaluation, I want to make sure I give a tailored more intervention. So I always like to make sure address the barriers that they're going to have to treatment that I'm recommending. So while I'm testifying, again, because that's always in the back of my mind, I'm going to get more specific. So yes, I may say individual therapy is what I'm recommending, but what type of individual therapy? If I have an individual that may be lower cognitively functioning, CBT may not be a good avenue for them. It may not be appropriate. So they may need more behavioral approaches. If I have an individual that, in terms of oral medication, even though I'm not a psychiatrist, that records document that they may need to look at long-acting injections. So you want to make sure your interventions are more tailored for the individual. If it's supervised living, that's probably a whole topic and conversation to itself. We can spend a whole hour just talking about when and when not to recommend supervised living. But I will say that make sure that you have the evidence to back up that as a treat, if that is an option that you're going to offer, you have to make sure that you can justify that supervised living. That's getting into, can the person care for themselves on a day-to-day basis? Because that's definitely a more restrictive treatment option when you put someone in supervised living. And so you want to also incorporate support from the community, peer groups and a case manager. You want to look at making sure those services are there. What is it going to look like and what's best for the individual? And so when it comes to looking at the clinical cert itself, when it comes to it, you're going to look at, make sure you thoroughly complete everything on the clinical cert. So one of the things is you're going to make sure you fill in the diagnosis. This here is, some people, I am more conservative. This is just my approach to it personally. I've only interviewed a person probably maybe less than an hour usually. It never get more than 60 minutes in terms of an interview. And so when it comes time for the clinical cert, I have to state the diagnosis, unless they have a long history of where I can say, I feel very confident this is what it is, and I can say it's bipolar 1 or 2, I'm going to use unspecified. That's just me being more conservative, feeling like what I can justify in court, because again, it still meets the criteria where I will use unspecified bipolar spectrum or unspecified schizophrenia spectrum. I will use unspecified very easily because I don't have enough records to know, and they may have been using substances, and I know they have a mental illness, and I don't have enough data within this time period to get it. So I'm known for using that. I will not just stand on it because it has happened to me. I have been in court where I have had to testify and with an attorney, some ones are more zealous than others, and spend time going over the difference between bipolar 1 and bipolar 2 and spending in-depth conversations defending why they don't have bipolar 1, bipolar 2. And it didn't even make a difference from a clinical search, from an AOT standpoint. But what the lawyer's trying to do is just trying to draw out like, well, if you can't explain the difference, then maybe you don't know what you're doing and discredit you. And so this is why that unspecified provides me a little bit more leeway in terms of my testimony and not getting caught up into explain difference between bipolar 1 and bipolar 2. I can do that, but it allows more leeway when I'm testifying. Also, in terms of the treatment necessity, you have to make sure they meet the criteria in terms of those 3 criteria I met. And again, immediate harm to self, and again, harm to self intentionally or unintentionally. A lot of times they may not intentionally harm themselves. Unintentional harm to self can come easily because untreated, the individual may get into a fight with someone else that may unintentionally harm themselves, and they may find themselves be assaulted by someone else. And that's happened many times with many people that I've evaluated, that they weren't suicidal, but they did put themselves in harm's way because of their mental illness, that they would, maybe they're paranoia, and then they're accusing people of things, and they go to the wrong person, and now they've been assaulted, and they've been put in the hospital because of that. That would meet the criteria. Also, when it comes to the looking at it, harm to other people. Are they going to go out and maybe get into a fight with someone else? Um, are they able to take care of their ADLs, right? So their basic needs. And then are they going through a period, the third criteria, are they going through a period where they don't recognize a need for treatment? And so that sometimes you may just hit the criteria there. You do only have to meet one of the criteria in those boxes. I know sometimes you may feel obligated, you have to hit all three. You do not. Only you have to check one of those boxes, one of the three boxes. In terms of looking at ethical considerations, as always, you inform consent. Before you start your evaluation, make sure you read that statement on the clinical cert to make sure you tell them why. And without that, that is sometimes a question you will get. I've seen some newer people who start doing evaluations and get a whole case thrown out because the lawyer asked them, did you read that statement on top of the clinical cert first? And the psychologist did not. And the whole case, well, it's dismissed. It gets thrown out on a technicality, even though that person probably met the criteria because you didn't do that. Understand that confidentiality also is a little bit different because you are telling them that you're going to be testifying in court. It is going to be open, that people are going to kind of hear this information. So it's a little bit different than what happens when they meet with their normal provider, where that's more confidential information. Always you want to respect their respect and provide respect and dignity to them and autonomy. You want to respect their autonomy, that they still have decision making, even though you are maybe recommending a court order treatment, you want to respect autonomy. So this is why I always like to say, if I'm going to do this and we're going to go a court order treatment, are you agreeable to some parts of it? Just something, because my goal is not to have you on this. I want to eventually get you off of this. And so I always tell them, hey, this is what I believe. We're going to do this, but my goal is to provide you the support, the treatments that's necessary that we can eventually get you off of this. This is not a lifelong thing. There is no reason people should be on AOTs for years in the key comment. That means maybe our treatment recommendations are not going well. We need to look at maybe the treatments that are offered and what we're doing, or go down a different path. And so that's just respect for them and as an individual. And also you have to be sure of different biases that we may have. We have to always check our own biases. Just because this person has been in, has a mental illness, a significant mental illness, and they've may have treated different providers this way, you want to check your own biases to make sure you are really evaluating this person from a neutral standpoint. Just because it's been recommended they have an AOT does not mean that they need an AOT. And so as an evaluator, you want to be neutral and go into this with eyes wide open. There are times that I get evaluations and I will say, you know what, I have to tell the caseworker, yes, they have a mental illness, but they don't meet the criteria. And I'm not going to go along with you. And it's unfortunate, and told the court the other day that on an individual case that I had to do a negative search on the individual. I will do that, that they don't meet. So you want to check your biases, that you don't go into it thinking that they need a AOT automatically or they don't need one, just being neutral and open to all the information. And so with that, next slide, I will take questions, or ever have questions, you can, my email contact there is that's the one. Well, I check my Wayne State one as well too, but I use too many email addresses. So any questions people may have?
Well, first of all, I just wanted to say thank you. That was really, really amazing. Yeah, you touched on so much that does go into a thorough AOT assessment. And I especially liked your focus on, on the, kind of the techniques you use to assess what their insight is into their own, mental health situation, being that is one of the special criteria for that assessment. So I appreciated your focus on that. So you started to talk about examples a little bit like at the end there, and I guess I wanted to ask a little bit more about that. Are you able to give like an example of someone who was referred to be evaluated for AOT, but you thought they didn't meet criteria and like what led you to this decision and like more specifics around that?
Yeah, so give an example of maybe you get an individual that is been referred for an AOT and you're doing the evaluation. They have a mental illness, maybe. Would be probably obviously they're probably that's why they're being referred, of course. But you look at their treatment, right? And so one of the things is have they been complying with treatment and why they may not and they may not just say they missed a couple appointments, and it may only be a few appointments, right? But they have legitimate reasons. So like I've had going back, I think I had a case, it was years ago, where the person was not they lived too far away and they had legitimate transportation issues why they was missing all of their appointments, and it's like, and if there are different areas the buses run, in certain areas the buses don't go out to certain rural areas. And that was a legitimate reason. It's like, well, they wasn't trying to purposely dodge treatment. And so in that situation, it's like if they had access to transportation, they probably would be complying with treatment. They wanted treatment, in fact, and I can tell they wanted treatment. So in that situation there, although they missed all these various appointments, that individual did not necessarily meet criteria because they were willing to go to treatment. They were not at harm themselves, even though they were not getting the medication treatment they needed at the time, but it was a legitimate reason. And so I just didn't feel I can go and justify putting them on a court order or recommend a court order for a person like that. Sometimes in other cases, you just may not have enough information, to be honest. You may not have enough historical information. Especially it's more challenging, like if it's the first time and they've only been hospitalized one time, and that's the only hospitalization they have, and no treatment history before that, you don't know what they're going to do, and so like this rush to put them on a court order, that may be more problematic. It's like, well, give the person a chance before you kind of put them on a court order. So that can be something that may happen. There's other cases, of course, as I mentioned, just more diagnostic reasons that they may not meet the criteria. So as I mentioned, like someone with dementia, that's a common one that you get. Someone, if they have dementia, that does not meet the criteria. Although they need help, it does not meet the criteria unless they have an accompanying other problem that goes on. Or you may have somebody with a substance use disorder. That's another one that you got to, well, what happens if the substance use is gone? Does the depression leave or does this, I'm trying to find that out. And so those are those balancing acts that you have to look at. Do they really require substance use treatment or is it something else going on?
I have a question.
Hmm.
I was wondering, where do you find that checkbox of the orders? Because it's not on the search. So where do you find that?
The check boxes for what part? I'm sorry.
For the orders. So at the end with specialized housing, case management.
Oh, so that is another form that is usually accompanied. So you yourself do not, as a provider, do not usually have to click those boxes unless we're talking about judicial admissions, something different. But normally there's a form that's completed and what you're recommending. Normally the provider does not necessarily have to click those boxes, but there's certain ones. I don't know if you guys have that on the like your toolkit listed as one of the tools, but there's a list of criteria like as individual therapy, group therapy, case management, sort of community treatment, blood urine analysis, all those boxes are checked.
Yeah, so and usually if I'm testifying, I don't have to provide that information, but then I was testifying in a different county's court system and they did want us to list all of those. So it kind of threw me off for a second. So just kind of wondering, but thank you. I will look for that.
Yep. Yeah. I've looked at the chat. Paula listed it's PCF 216 where it has all the different options. So
Great, thank you.
And sometimes I am asked the question, sometimes I am not. It just depends on the court you're testifying in, as well as the lawyer. You know, to be honest, that I hate to say it, the lawyer that makes a big difference in terms of the questions you're going to get on the stand. Some are tough, and some is kind of like, oh, whatever.
So, yeah, I was curious. You touched on some things that we have talked about in this space before, not only um, folks with dementia and Alzheimer's being petitioned and on an order. I know that's been brought up in this space very frequently in the past, as well as, making those distinguishments, making those distinguishing assessments for AOT consumers, whether they're SUD primary or, or not. So navigating those things. So I guess I just wanted to kind of put focus on that and bring that specific subject to the group and ask, is anybody currently or in the past having issues navigating, AOT consumers and who are experiencing either of those things, or have any specific questions about that?
It sounds like I've been summoned.
I didn't want to call on you.
I was waiting for Dr. Smith. I thought he was going to speak up as well, since we all of us in other meetings have certainly talked quite a bit about this. I just wanted to mention I'm certainly the troublemaker when it comes to bringing this particular topic up. I just have so many questions, and more or less a lot of them are aimed at how things on the east side of the state are being navigated when it comes to I guess some of the additional barriers that come along with the senior population, even ones that you mentioned in this the presentation just earlier there. So I guess I was curious, typically what we have here in Muskegon County is I will often refer to either my own CMH people or our geriatrics collaborative. We have a pretty good collaborative connection with a geriatrics office specifically here in Muskegon County. So I feel that's beneficial as well. Whenever we do have conversation with even like a visiting nurse that's affiliated with the geriatrics office, she also mentions a form called a PC 630 that seems to come up often. And I'm not sure if anybody in the venue here knows of that form as well. But I don't, unfortunately. So
it's largely exclusively used to manage and project medication-based needs. So it's far more specific to somebody while they're either inpatient or being ordered into some type of longer-term care. So that's probably why you see it come up a lot with your older adults. And for the record, you are never a troublemaker. The issues surrounding our aging population and the intersection of mental health and neurocognitive decline, neurocognitive conditions really is one that nobody is taking serious enough. And we're on the precipice of, I think, a real challenge. And as we've talked about in this forum before, we're losing a lot of med psych beds, which are going to be the only option for a lot of those individuals to receive inpatient care if they need it. So I'm always grateful that you're around to cause, maybe we'll call it good trouble, to borrow the phrase.
well, I appreciate that. Yeah, there's just so many questions that do come along with that, which I think are many of which we have brought up in previous discussions. But a lot of that is mainly just having to do with that crossover between, in my case, senior related investigations, where there is also that component of potential mental health issues at play as well. And it seems like when attempting to provide assistance to that person on either side, oftentimes it seems like both avenues will say refer to CMH or refer to geriatrics, and it seems like it has that revolving door potential quite often. So I guess to that, Brian, I was hoping that if you had any familiar. Oh, sorry, you're muted, Brian.
Oh, sorry.
Yeah.
So in terms of this is like I said, I've recently just had a few cases where I've had individuals with neurocognitive. I've been seeing a lot more, and it's challenging because you do the evaluations, like they need help, but there's no way I can help. This is not the mechanism for help. I've been referring back, back to CMH and seeing where we can try to get help, where we can. A lot of times it's trying to find, like, even if they may need the guardianship, sometimes with some of these individuals where I have to recommend, like, case manager, you may need to talk to family about guardianship and then look at finding, but beds itself, that's a whole different, good luck, to be honest, if the families have money and they need like a residential type setting. But a lot of times in those evaluations, I've made refer back to the case manager, and try to say, well, maybe they need a guardianship, maybe try to look at a power of attorney to try to provide, then try to get treatment for them that way, whatever the treatment may look at. But it's really kind of like I said, I went to court just, what was it, a week or two ago, and had a case. The judge and we just kind of threw our hands up, like, we don't know what to do. We left out of court. We just had an individual, they had dementia. They didn't have nothing else to go along with it other than dementia. And it's kind of sad. So they kind of fall through the cracks, to be honest. And I don't know the solution of what we need to do as a state to kind of remedy that situation.
Yeah, I'm glad you mentioned that. Like, I'd say that would be my most familiarity as far as things that we've been exploring, at least for roughly a year, almost about 2 years now, is luckily having the support of our probate court here in Muskegon County, where I know that is not similar with other counties, even in the state, where it just looks completely different as far as petitioning someone more or less to even just get conservatorship, let alone combined conservator guardian, which is even more difficult. But I think at least in Muskegon County, it's been very supportive overall with designated guardian ad litem support, and also with the probate judges that are taking in a pretty hefty amount of petition based situations where we are referring them in order to set people up for protection, even if they aren't aware that they need it. So I know that there's a gray area there as far as the rights, but
Yeah,
it takes a lot to accomplish all that.
it definitely does. I definitely agree. It takes a lot. I would say in Genesee, at least I feel like they're very progressive in terms of the court and the probate of helping out in those matters. So I don't know how it is in different areas, but as you mentioned, certain areas are probably more challenging if you don't have the support of the probate court system to help you out.
Mm-hmm. Thank you so much, Dr. Littleton. I'll go ahead. We're at time, so I'm going to go ahead and stop us here. But thank you so much for coming and presenting today. Just want to thank everybody, whether you're returning or you're new. Thank you so much. Reach out to me if you have any questions or inquiries or feedback or anything like that. And this PowerPoint the slide deck will be emailed to everybody on Monday at my follow-up email, and the recording will be posted on our toolkit. So again, thank you so much. Have a wonderful weekend, and yeah, we'll talk soon.